I'd like to welcome you to this session of the Center for Podiatric Education, and in this session I'd like to speak a little bit about evaluation and management of high ankle sprains, something that we see in general practice. Those with sports medicine practices obviously are more apt to see this on a regular basis. I think for the everyday podiatric physician, there's a tendency perhaps to underestimate the prevalence of this problem and perhaps miss the diagnosis. It has been estimated by some that about 15% of all ankle sprains involve the syndesmosis. These patients come in, their findings can be rather unappreciated, particularly if we get the initial impression that this is going to be just a simple ankle sprain. So the clinical findings can be rather unimpressive on first glance. We know that high ankle sprains are associated with a pronation external rotation injury, and that is to say that initially there's going to be some injury to the medial aspect of the ankle in most cases. This can either be an avulsion fracture of the medial malleolus or a rupture of the deltoid ligament. With continued lateral rotational force, the talus will butt up against the fibula, and we will have some failure of the interosseous ligament to some degree. Again, this is something that, unless specifically examined for, is frequently unappreciated and the diagnosis is not made. When patients sustain a high ankle sprain, particularly non-athletes, this can result in considerable delayed recovery. The patient continues to talk about pain and swelling and tenderness on the anterior lateral aspect of the ankle or posterior lateral aspect of the ankle. And at times the outcome following high ankle sprains is quite poor. We want to make sure that when considering a patient for a high ankle sprain, we consider the possibility of a more proximal fibular fracture, a Maisonneuve fracture. There may again be injury to the deltoid ligament. There may be an osteochondral fracture, particularly where the talus impacts into the lateral ankle complex. Thinking a minute about the anatomy, we have looking at the anterior aspect of the ankle, the anterior inferior tibial fibular ligament. This attaches to the tibia at the tubercle of Chaput. It attaches to the fibula at the Wagstaff tubercle. And we want to remember that in addition to a rupture or strain of the anterior inferior tibiofibular ligament, we can have an avulsion fracture at the insertion into the tibia, the Chaput fracture. We can have a avulsion at the insertion into the fibula, Wagstaff, or as my German friends like to say, Wagstaff fracture. We can have injury to the interosseous membrane and interosseous tibiofibular ligament. Looking at the posterior aspect of the syndesmosis, we can have avulsion of the ligament from its insertion into the posterior inferior tibia, and that would be a Volkmann fracture. And we can have avulsion from the fibula, although this is less common, and we certainly can have injury within the ligament itself on the posterior aspect. Again, we can appreciate the anatomy of the anterior inferior tibiofibular ligament, and we can see that it does blend somewhat on the anterior inferior lateral aspect with the anterior talofibular ligament, and one can see how some confusion can arise, particularly when the maximal injury is in the area of the Wagstaff tubercle, and at times it can be difficult to appreciate the fact that indeed there has been injury to the tibiofibular ligament itself rather than just a typical injury to the anterior talofibular ligament. Again, looking at the anatomy for a moment, we have the tubercle of Chaput on the anterior lateral aspect of the distal tibia at the insertion of the anterior inferior tibiofibular ligament, and we have the Volkmann tubercle where the posterior inferior tibiofibular ligament lies, and we have, of course, the insertion into the fibula on the anterior aspect, so-called Wagstaff's tubercle. So we have classic ruptures of the ligamentous structures themselves of the syndesmosis, and we can have variations with avulsion fractures and combinations thereof. Looking at the strength and stability of these ligaments when subjected to pronatory and external rotary forces, the anterior inferior tibiofibular ligament provides about 35% of the stability of the syndesmosis, the posterior inferior tibiofibular ligament about 40%, and the inferior or the interosseous talofibular ligament about 21%. Again, the typical mechanism of injury, although not exclusively, is a pronation, external rotation injury. We have typically initial medial failure of the ligamentous structure or fracture of the medial malleolus, lateral rotational force applied by the talus to the syndesmosis and fibula. We then have injury to the ligamentous structures themselves. In some circumstances, however, we can have the high ankle sprain without fracture and lesser degrees of deltoid ligament injury. So in evaluating patients who have a high ankle sprain, we're going to look for fractures at the tubercle of Chaput, the Wagstaff fracture, possibly Volkmann's tubercle. We're going to look at injuries to the medial aspect of the ankle joint, particularly the deltoid ligament, and the various components. Oftentimes, some components, the tibiocalcaneal ligament, for example, will remain intact, as does frequently the posterior tibiotalar ligament. So that careful examination is required from the knee joint, really distally, including the tibia fibula, and a detailed examination of the ankle joint itself. These patients will present with varying degrees of swelling and various degrees of ecchymosis. It is not true that high ankle sprains are necessarily associated with, quote, a worse clinical presentation, unquote. We may see a higher level of ecchymosis present, suggestive of some injury, as we see in the upper left-hand corner. We may have ecchymosis that looks more typical of rather everyday ankle injury. We may, as on the upper right-hand side, see some medial ecchymosis and bruising, and this again would tell us that we have to examine more carefully for injury to the deltoid ligament or injury to the medial malleolus. Just as a reminder, there are associated injuries associated with these high ankle sprains, and we want to be careful to evaluate for higher fibular fractures, for some degree of more extensive rupture of the syndesmotic interosseous ligaments, and we want to look for deltoid failure or medial malleolar fracture. X-rays may demonstrate indeed increased medial clear space and increased gapping or lack of overlapping of the tibia and fibula on anterior posterior ankle joint X-rays, and this may be evident not only on the AP view but possibly the oblique view. Again, when we see bruising and pain and tenderness on the medial aspect of that ankle joint in the area of the deltoid ligament, together with tenderness and pain higher than we would normally anticipate finding the anterior talofibular ligament, one has to raise the suspicion and evaluate the patient for possible syndesmotic injury. When mediomalleolar fractures are present, treatment of these is going to have to be included in our management, and we certainly want to reduce the deltoid ligament and close down the medial clear space in addition to our considerations for possible repair of the syndesmotic ligament itself. We want to take higher x-rays, such as in this case, where we see an increased medial clear space. We see what appears to be decreased overlapping of the talus and fibula on anterior views, and we have a more proximal fibular fracture, so that this x-ray would imply rather significant injury and failure to the deltoid ligament, failure of the syndesmotic ligaments, as well as a higher fibular fracture, again implying a pronation, external rotation type of injury. The clinical examination is going to include a preceding history. We are going to examine again these patients from the knee joint down. We're going to look at the area of maximal tenderness and perform modifications of stress testing. We're going to look for that higher level of bruising above the level that we typically see with injury to the anterior talofibular ligaments, and pain and tenderness in this area. And when we see this, we certainly have to become suspicious for possible higher ankle injury, a high ankle sprain. And again, in general, we're going to see a higher positioning, more proximal positioning of tenderness and discomfort over the area of the anterior inferior tibiofibular ligament, rather than just pain and tenderness in the area in which we typically find tenderness, ecchymosis, and swelling with injury to the anterior talofibular ligament. From a clinical perspective, there are some standard tests that can be done. One can squeeze the tibia and fibula together. Obviously, if there's an injury in this area, one would expect that there be reported pain on compression by grabbing the tibia and fibula and squeezing them together, irritating the injured area. One can externally rotate the foot relative to the leg, holding the leg stable, and here again, this is going to stress the syndesmotic ligaments. It's going to stress the medial ligamentous structures of the ankle and may be quite painful. Or one can do testing by dorsiflexing the ankle and compressing simultaneously. So the squeeze test is probably the most common test that we do in evaluating patients for syndesmotic injury, and we go ahead and compress the tibia and fibula and see if this elicits pain in the area of the injured syndesmotic ligament. We can stabilize that leg and dorsiflex and externally rotate the foot. Here again, this will result in some reported medial pain as well as pain in the area of the syndesmotic ligaments. As far as radiographs go, we certainly want to obtain x-rays in the knee area and proximal tibia and fibula when it's appropriate to do so. We may want to obtain stress eversion injury radiographs of the ankle to see if we can gap that area of tibiofibular overlap, which we typically see on standard x-rays, to see if we can increase that medial clear space. We want to obtain standard radiographs of the foot as well as the ankle. If we suspect that there is indeed significant injury, particularly if surgical intervention is planned, then either CT scans or MRIs would be helpful for delineating the details of the injury itself. Some have also suggested the performance of stress eversion testing utilizing diagnostic ultrasonography. I think most people listening to this are familiar with the standard radiographic evaluation of the ankle joint. With reference to high ankle sprains, we're going to look and see if we have an increased medial clear space, if that medial gutter area between the medial malleolus and medial aspect of the talus is increased. We're going to obviously look at the symmetry that's present in the articular surfaces of the talus and the tibia. We're going to look at the area of overlap in the fibular incisura between the tibia and fibula itself, and we're going to look at the actual width of the space. And we see some variation reported in the literature. In general, it's felt that about 1 centimeter of overlap is present on your anterior posterior x-rays, and we generally look for at least 5 or less than 5 millimeters of clear space between the tibia and the fibula. So depending on the extent of the injuries and the specific natures of the injuries, we may see specifically increased medial clear space. We may see a fracture and avulsion fracture of the medial malleolus. We may see some osteochondral lesions. We see a lateral displacement of the foot relative to the leg. We may see increased clear space between the tibia and fibula. That is to say, decreased overlap between the tibia and fibula. And we want to be careful looking at these x-rays because these changes can be somewhat subtle, as they are, for example, on the right-hand side. But when we see such x-ray changes corresponding to clinical findings of more proximal ecchymosis, more proximal pain or tenderness, then we have to consider the possibility that indeed that particular patient sustained a syndesmotic ligament injury, that is to say a high ankle sprain. Another example with increased clear space or decreased overlapping, if you will, between the tibia and fibula with the presence of an osteochondral lesion at the site where the talus impacted against the fibula itself. These changes can be more subtle, and again, the argument for, say, CT scans or the arguments for ultrasonography while performing stress eversion studies. MRIs are very helpful for elucidation of the anatomy of the anterior inferior tibiofibular ligament, as well as elucidation for the anatomy of the posterior inferior tibiofibular ligament. MRI studies are extremely sensitive and specific for injuries to the anterior inferior tibiofibular ligament as well as the posterior inferior tibiofibular ligament, and these injuries are easily recognized and diagnosed by use of MRI study, and this is generally recommended. As I mentioned, one can send the patient off to radiology for stress eversion studies utilizing ultrasound to detect more subtle injury to the deltoid ligament or to the syndesmotic ligaments. There are various grading systems available for evaluation of high ankle sprains and recommendations made for treatment based on such grading systems. This is the West Point system. With grade 1, there's really a microscopic tearing of the ligaments of the syndesmosis with minimal swelling, no obvious joint instability, and the patient is able to fully or partially weight bear. With a grade 2 injury, there is partial tearing of the ligamentous structures with moderate swelling, sometimes severe swelling, some degree of instability, and the patient is not going to be bearing weight. With a grade 3 injury, there is a complete rupture with significant swelling, significant instability, and again, no weight bearing. With regard to usefulness of the West Point system, In general, a mild microscopic tear recovery is felt to be adequate typically at 6 weeks. With a partial tear, recovery seems to be adequate in 6 to 12 weeks. With a severe tear, that is a complete tear of the syndesmotic ligaments, typically requiring surgical intervention, we're looking at somewhere between 3 and 6 months for complete recovery. With regard to treatment of high ankle sprains, the major considerations are listed here. Number one, what is the degree of stability or instability of the ankle joint? Number two, what are the concurrent injuries that are present in terms of fractures and ligamentous ruptures such as deltoid or OCDs? And what is the patient like? How healthy is the patient? What is their activity level? This will certainly influence our decision making. The non-operative management for grade 1 and some grade 2 injuries includes usual rest ice, compression, and elevation, and then efforts to increase blood flow with heat and physical therapy, compression to eliminate swelling, and measures to improve mobility, initially with physical therapy and assisted efforts. Phase 1 has included injury protection, pain relief, and the use of anti-inflammatories when the injury first occurs. Second phase for non-operative management is to attempt to regain full range of motion. Now again, we're talking about microscopic or partial tears. In physical therapy, this can include massage therapy and exercises to mobilize the scar tissue. Next, there's efforts made at muscle strengthening to regain a muscle strength lost during the initial care and following the initial injury, and a gradual progression of the patient from non-weight bearing to partial weight bearing to total weight bearing. In phase 4, efforts are made to normalize the biomechanics of the lower extremity, foot, ankle, and leg. In phase 5, efforts are made to restore speed, power, and agility to the athlete, and for those who are part-time athletes. And then, of course, phase 6, there is a return of the patient to their normal activity level. More severe syndesmotic injuries require surgical management. Now, the nature of the surgical management does depend on some degree as to whether or not there is a requirement for repair of medial ligamentous structures, the deltoid ligament, or repair of the medial malleolar fractures that may occur. And also there is some variation depending on whether or not it is the ligament that's torn or whether there's an actual avulsion at the level of the Chaput fracture or Volkmann's fracture. Many of these can be easily treated by minimal incision techniques, really. Typically, we're going to insert our syndesmotic screws about 2 centimeters above the ankle joint line, and frequently we are able to percutaneously reduce these injuries and then fixate these percutaneously. There are a variety of techniques that have been advocated in the literature for the surgical repair of the syndesmosis and high ankle sprains. And all of these techniques have papers that argue in support of their approach. This includes the use of standard screws, absorbable screws, the use of screws through washers, the use of screws inserted through small bone plates, and then there are suture button techniques. Generally, it's accepted that the ideal positioning of the reduction is going to be 2 centimeters above the ankle joint line. With regard to screw size, there continues to be some debate regarding this matter. Some have argued that really once one gets over 3.5 millimeter screws, that there is no real advantage to proceeding with larger screws. But again, this has been subjected to continuing argument. so that we see those that advocate 2 screws through 3 cortices, those who advocate a single screw through 4 cortices. Realistically, one's going to pick the papers that they feel are most compatible with their individual philosophies and follow that. Some have argued there's really no difference in outcome when we look at the results of the various fixation techniques, provided that the patient is adequately reduced and the surgery adequately performed and the post-op rehabilitation was properly followed. In this particular study, authors recommended 2 tricortical screws. This was the famous injury to the ankle joint of Terrell Owens, the Hall of Fame receiver. I say famous because I've been a long-time Philadelphia Eagle fan, and Terrell Owens had injured this ankle prior to the Super Bowl, and it was felt that he would not be able to return to play, but indeed he did return to play in 7 weeks and participated in the Super Bowl. These were actually his x-rays with syndesmotic reduction utilizing screws with 4 cortices through a bone plate. Some have advocated the use of absorbable fixation, arguing that this eliminates the need to remove the syndesmotic screws. And there are some papers, such as this particular study, showing that even with repetitive loading, there's really no difference in mechanical characteristics between the use of absorbable and steel screws. In using rigid fixation for syndesmotic repair, we eliminate, obviously, all of the fibular motion. This results in limited tibio-talar contact and potential for screw fracture unless the screws are removed. And such fractures of the screws may be associated with swelling and pain and stiffness. And I think that while there have been some papers that have argued no need to remove these when fractured, I think in general it's wise to remove the fixation screws before allowing full weight bearing and full mobility. We've seen in recent years arguments made for benefit of use of suture button techniques of various types with various alterations in application. The argument being that the suture buttons are going to allow stability with some slight motion, do not require removal, and if broken, really the argument has been made, well, who cares? So there are those who argue that some fibular motion can be allowed, and we don't need to subject the patient to a second surgical procedure. They can, of course, break, and these things can fail with pull-through failure, so that there are some complications that can occur with suture button techniques, as with any surgical procedure. There's been a good deal of science and investigations looking at these suture button techniques, and the techniques have been well described in the literature. Again, a variety of alternative techniques may be utilized for high ankle sprain reduction and stabilization. I think that regardless of the technique utilized, again, the key is whatever approach one uses, it should be done well. And you want to make sure that you have adequately reduced the syndesmotic disruption, that you've accounted for concurrent injuries such as medial stabilization, OCD injuries, and so forth. Following syndesmotic repair, generally splinting is utilized for 10 days to 2 weeks, then non-weight bearing for up to 10 weeks, following which there is weight bearing allowed utilizing a fracture boot or cast. Physical therapy then follows, and of course screw removal. Just as a reminder, you want to make sure that the patient is evaluated for more proximal fibular fractures, for rupture of the deltoid ligament, for fracture of the medial malleolus, and when appropriate, fixation and repair utilized for these structures. With everything else, of course, there are those that have advocated the use of platelet-rich plasma injections and other biologic therapies to, quote, speed recovery. Generally, the hopping test has been said to tell us when the patient is ready to return to play. There's some variability in return to play depending, again, on a number of factors, including the staging of that syndesmotic injury, whether it is mild, moderate, or severe, that is a 1, 2, or 3, so that patients with lesser expressions of syndesmotic injuries can return earlier, and obviously patients with more severe injuries will be delayed up to 6 months. So in summary, the high ankle sprain is something that is generally unappreciated by many on initial evaluation, and this is particularly apt to happen, in my opinion, with doctors who really do not have active sports medicine practices, and we tend not to do the same detailed examination and tend to think everyone has just a lateral ligamentous injury. Remember that these occur with pronation, external rotation injuries. Typically, delayed recovery is very typical for these injuries. Detection requires a proper examination and attention to detail when evaluating the radiographs. You want to try to classify these injuries in your mind as to whether they are microscopic tears or strains, whether or not there is a partial rupture or total rupture. You want to make sure that you've defined the collateral or contiguous injuries that can occur, and then initiate appropriate therapy. Thank you for listening to this session.